Hello and welcome to Bridging the Gap, the interview series that brings together leaders in healthcare to discuss the latest innovations impacting behavioral health and behavioral health integration. I'm Chris Molaro, the co-founder and CEO of NeuroFlow, and I'll be your host today. Today we're speaking with Ryan Kruis, Director of Grants and Research at MUSC, that's Medical University of South Carolina. I'm super stoked for this because he talks about how to leverage state grants, philanthropic grants, government grants on how to really promote innovation to move the needle in healthcare and work with companies like us. We work with them across all of South Carolina. We're really proud of the work that we do. I learned a lot from Ryan in today's conversation. So without further ado, welcome Ryan.
All right. Well, thanks for joining me, Ryan.
Yeah, thanks for having me. I'm excited about this.
Well, just so everybody knows, Ryan and I are joining you live from NeuroFlow headquarters. We're at our second annual summit, bringing clients, partners, healthcare leaders together to talk about the industry and trends and so forth. And we're in the second day.
Yeah.
It's been a long 2 days.
Yeah.
But before we jump into it, can you maybe just tell the audience a little bit about your role at MUSC?
Sure, yeah. So I'm Ryan Kruis. I've been with MUSC now for 7 years. I work in our Center for Telehealth, and I'm the Director of Research and Grants. That role has developed over time. Just a little bit about MUSC to give you some
please.
context. Yeah.
MUSC, what does that stand for?
Yeah, great, thank you. The Medical University of South Carolina. I get so used to the acronyms. So MUSC is one of the largest academic medical center in South Carolina, and as such, we're the primary provider of specialty care in the state.
Wow.
We also have a really large rural population. Over a third of our population is considered rural, and being one of the only providers of specialty care in the state, we have really charged ourselves with the mission to extend access in innovative ways to a lot of these rural communities. And so we've been doing that via telehealth for a long time, way before COVID made telehealth cool. And really it was in 2013 that our state legislature invested a fair amount of funding in our telehealth infrastructure that allowed us to form our Center for Telehealth and really start innovating and thinking about new creative ways to get healthcare out there, including behavioral health.
I've been on site there. It's in Charleston.
Yeah.
It is innovative. It does not feel like you're in a hospital setting at all. It feels more like you're in Palo Alto.
Yeah, we've got carts and remote patient monitoring devices. It's a great space to kind of demo the equipment and technology to both our providers, but also legislators, funders. We bring philanthropists in there, and everyone's really excited to see kind of firsthand what this can look like and how healthcare is innovating.
So headquartered in Charleston, but really supporting the whole state.
Yeah. We have over 16 hospitals now that we either own or have a joint partnership with, and then additionally over 60 some primary care offices, other ambulatory settings, and then we have a lot of partnerships. Being one of the only academic medical centers, we're strategically partnered with some of our universities providing behavioral health care, FQHCs in the state, different state agencies.
Wow.
So there's a lot of good, exciting partnership happening too beyond the formal MUSC walls.
Now, what's so interesting, if you have to cover a whole state,
Yeah.
Charleston is different than Columbia,
Yep.
is different than Myrtle Beach,
Yep.
and then all of the rural areas in between there.
Yeah.
I'm sure that the population on the coast is different than the population inland,
Yeah.
and their needs are different.
Yeah.
How do you manage all of that?
Yeah.
The changes, just the differences.
Yeah, well, you hit the nail on the head. And, Charleston, the coastline, we're getting a lot of folks moving down. It's a great place to retire. It's a great place to visit, but,
That's the South Carolina pitch?
Yeah.
Is that okay?
But, down the I-95 corridor, what we call it, it's got some of the worst outcomes in the country.
Like health outcomes?
For health outcomes.
Really?
Comparable to, some of developing countries. And so...
Wow. Like what? Like, can you give me some examples?
Yeah, like we have counties that we don't have a practicing pediatrician in counties.
What?
So that's where our school-based telehealth program becomes really critical,
right.
Trying to meet kiddos where they are. We have APPs and pediatricians that beam into carts in the schools.
Right.
That's one of the innovative places that we are layering on some of the behavioral
Wow.
health initiatives. But stroke. Sometimes South Carolina, that part of the country, is considered the stroke belt because of such high rates of stroke. So, again,
is there a reason for that?
It's a mixture of probably historic.
I've never heard the stroke belt.
Yeah. Well, it's I think across the board with public health, you've got these historic social determinants of health, systemic racism, and other things that have influenced some of the dynamics in the areas. But then also, one of the kind of emerging issues that we're seeing a lot is just funding for rural healthcare generally. A lot of primary care offices that have a very difficult time making ends meet, and then rural hospitals are closing, or a lot of times because different specialties aren't available, rural hospitals get bypassed, and so it makes it really hard. And a lot of these rural hospitals are really the economic engines in some of these smaller communities.
Right, like the biggest employer, I'm sure, right?
Yeah, so figuring out innovative ways using telehealth and unique ways of partnership to keep care local, but augment that via telehealth has really been critical for us.
So were you doing telehealth pre-COVID?
We were, yes. So we've been doing telehealth. It probably started with a maternal fetal medicine program back in 2004.
Before it was cool. Yeah, you were doing it.
But it definitely, I would say, COVID certainly allowed telehealth to become more mainstream and has really become. We moved from largely serving rural health and doing a lot of partnerships and to thinking as a health system, how can telehealth really get embedded across all of our departments? How can we use this to mitigate some of the challenges we're facing around workforce burnout, workforce efficiency? So there's a lot of good opportunities that telehealth can have in this evolving healthcare landscape.
Out of curiosity, with telehealth stuff, does that give an opportunity to talk to specialists from outside the state too? Like if there's a preeminent, cardiologist in New York, can you tele them in?
Yeah, my colleague could speak more to this program, but one of the really innovative things we've developed in the last couple of years, and this has largely been as a means to try to address some of our access issues and just capacity, is starting a virtual first practice. So we actually have rheumatologists and endocrinologists and more. We're continually onboarding new specialties. We've got hem-onc and others that are virtual only practice. So we've got a team of nurses that helps coordinate local labs, coordinate local imaging if that needs to happen, but all of the visits occur virtually. And so this has really helped us make a dent in some of our wait times for these specialists. And we're using it strategically to try to tackle some health equity issues too. Like, there's a large burden of sickle cell in some of these areas and along that corridor I mentioned. And so bringing on a hem-onc provider that can see patients in their homes has really reduced a lot of the wait times and increased access for this really high needs and population that faces a lot of other health equity issues.
Just because you brought up sickle cell, I'm familiar with gene therapies, CRISPR, and I think sickle cell is the first one to be started to be treated with CRISPR. Are you familiar with this?
I am familiar with CRISPR. I'm not.
Is that being done at
my expertise? But we have an evolving genomics group at MUSC, and
cool.
A really large statewide initiative focused on genetic testing. And so I think that's another area that we are trying to get access out. So if that is an option for folks, being able to have them see our virtual specialists and get triaged into this program. It, again, helps bring access to some of these more innovative technologies.
My daughter has cystic fibrosis, and we're lucky to be here in Philadelphia where we have CHOP, who's a preeminent CF clinic, and she's being treated. It's a good news story because she's treated, she's doing phenomenal, but CRISPR's on our radar because we think it might be the second or third disorder after sickle cell to be treated. So that's why it has my attention personally.
Yeah, well, I mean, if you think about, a kiddo living in rural Williamsburg, say, South Carolina, they're an hour and a half, 2 hours away from local specialists that can actually help them figure these things out. So that's where telehealth really has come in to help mitigate those gaps.
I think
bridge the gaps that you go.
100. I see what you did
Yeah.
there. I mean, it's just so I find our position, my position, especially to be so lucky to live here in Philadelphia. You live in a major city where we have some of the best healthcare available. Like again, Children's Hospital Philadelphia is 10-minute drive from my house. I can't imagine if I lived, people have to fly or drive hours and hours and hours to get that, and telehealth can help make that more accessible.
Yeah, exactly.
One of the things I love about MUSC is that you're so data driven. You're an academic institution. You're renowned outside of South Carolina for the research that you do. To that end, can you speak to maybe the outcomes related to telehealth? Is it good but not as good, or is it?
Yeah, I mean, it is. The research shows again and again that it is as good. There's obviously caveats, and there's certain things you cannot get addressed over telehealth. You need to do hands-on, but in general, we see outcomes are quite similar. And oftentimes when we're talking about telehealth too, we don't necessarily want to replicate care and have like a virtual version of what we were doing exactly in person. This is an opportunity to innovate and think differently. So, traditional model for primary care, for example, you go into the office, you get your 45 minutes, and then, if you need to come back, you come back a month later, drive in. Well, what if you can do lighter touch, whether it's texting, you can shoot a text off to do follow-up, check how medication is going, or you can do a quick asynchronous e-visit, or you could do a quick audio-only telephone visit that's just 10, 15 minutes. I think we're really starting to see, and a lot of this, as healthcare moves more towards value-based care, there's going to be more opportunities for this, but not just thinking about how can we replace what we're currently doing in a somewhat broken healthcare system, but trying to innovate and trying to find new ways of treating folks. And I think with behavioral health and with chronic disease management in general, there's a lot of opportunities for some of that more lighter touch and kind of being more precise in delivering certain kinds of care to folks.
I'm curious, I want to get more into BH in a second, but the mentioning value-based care or alternative payment models, what's the breakdown now at MUSC with that versus traditional fee-for-service?
That is a great question. I don't know the exact breakdown. We do have an ACO that we're participating in. We do do a lot of direct negotiation with some of our payers, but I unfortunately couldn't tell you the actual breakdown.
But I guess the breakdown is not purely in one or the other camp.
Correct.
So you do some fee-for-service. That makes sense. What do you think? I guess, what do you think the trend is? I mean, people have been talking about value-based care for 20 years now.
Yeah.
And fee-for-service is still, a player in the, at least on the financial side.
Yeah, I think things are moving in the direction of value-based care, but it's slow, and I think we are still heavily fee-for-service based.
Yeah.
So it's going to take some time. I think there's different incentives coming out, but different states have to opt in to participate in those, or different health systems.
Right.
I think it'll take time.
Well, one of the things I think, speaking about financials, one of the things you've done, especially given your role, is a phenomenal job with finding alternative ways of paying for innovation and these telehealth models. Some of the work that we do together with NeuroFlow through this, I guess you would call them grant funding, or I don't think, you said before the show that a lot of it was luck. Maybe so, but we create our own luck.
Yeah.
And I think it's just so, is there a secret sauce that helps you be more successful that other folks can learn out there so they can leverage the same avenues?
I think it's a few things. One, it's being in the integrated care space. So I obviously work in telehealth more broadly, but I'm trained as a clinical social worker. I got my start as a research therapist embedded in a primary care clinic. So because of that, that's where some of my own research and interests have developed. And it's a good time because there is a lot of federal incentives to, in the grant space for integrated care, SAMHSA, HRSA, they're putting out different integrated care calls. Similarly, CMS has a number of innovations going on. So there's a lot of interest and focus on behavioral health nationally in the research and grant making space. And so I think, one, it is our interests are aligned with kind of some of the funding focus at a federal level. So that's a big piece of it. The second, I would say, we've really been able to marry that with some other important focus areas like rural health. There's a fair amount of rural health initiatives going on right now, and especially in the last 8 years. And so being able to say, hey, we've got this innovative model, we know that rural is lacking access to behavioral health, and that some of the outcomes as a result are much worse than in their urban or non-rural counterparts. So we've got some ideas on how we can address that. And so those calls in particular have been particularly successful. And then similarly, we've also, in addition to more federal grants, worked closely with philanthropists and kind of nurtured relationships over time. And I think one of the exciting things that has, at least for telehealth, allowed us to be pretty competitive in both the grant and philanthropy space is by nature of a telehealth relationship, it's a partnership, right? It's a large academic center with an FQHC, with a small rural health clinic, with maybe a school or a local university. And those partnerships, I think, are seen as really exciting to philanthropy and to grants. And so I think maintaining those partnerships, leveraging those partnerships, and exploring ways to make sure that as we enter grants or philanthropic endeavors together, that there's equitable, we're both getting something out of this, that's been really key too. I think one of the things that's really exciting about that too is, as you mentioned, an academic medical center is where a lot of the innovation, evidence-based practice is getting generated and coming out, and sometimes it can take years for that to make its way out into a smaller primary care practice. And so through these partnerships, we're also really speeding that innovation to bedside pipeline, which is something I'm really excited about.
What is the threat when you're talking about grants and funding? This is a presumption, but I'm assuming that the granting organization, whether that's a philanthropic organization or a government organization, is doing so to overcome the financial barriers to test and innovate and adopt. Not necessarily, maybe in some cases, but not in most cases, the intent isn't to fund in perpetuity.
Correct.
And so that means the grant funding runs out for a particular project. Yeah. What do you do from a, okay, then what standpoint?
That's a great question. So sustainability is always kind of front of mind when we do any of these grant innovations. So a big piece of it is making sure we are collecting good outcomes data from the outset so that as we are demonstrating that this innovation can work, we can bring that to our payers and maybe do some direct negotiation or use that to advocate for payment. One of the things I'm really excited about, and I should say MUSC is not the only group in South Carolina, there have been others doing collaborative care, but we are very excited that South Carolina Medicaid is getting ready to turn on the codes, which joining a lot of the rest of the country finally.
You mean, can you just say, what do you mean the codes?
Yeah, sorry, the collaborative, the COCM behavioral health integration codes.
For the Medicaid specifically. Medicare reimburses for it.
Medicare reimburses, our private payers reimburse, Medicaid has not, and that has been a huge barrier for the adoption of COCM in South Carolina, but as of October, they're getting turned on, and a lot of that was a result of advocacy and data that we were able to share that was generated from grants.
That's awesome.
Yeah. Similarly, I'll just say too that having partnerships with whether it's your state or federal legislators around some of this work, we just got a fair amount of funding to invest in school-based mental health from our state legislature, and so that's really allowed us to get some startup money to really innovate, and then obviously we're going to bill for those services to try to make them sustainable, but really having some of that startup funding to kind of try things out, figure out what are the sustainable models has been really critical for us. And state partnerships, I think, is another great place for that.
We have, I think we have a special relationship with you and MUSC, speaking NeuroFlow and our organizations, and particularly on a personal level, coming from a behavioral health background in an integrated care setting. Maybe you could talk a little bit about the work that you're doing. I mean, you were doing integrated care prior to working with NeuroFlow. And then we came in to help accelerate it and scale it. Can you talk more about how that's working today?
Yeah, happy to. So we, as part of our longstanding telehealth initiative, we've been doing telepsychiatry into rural primary care for a while. That was more of a consultative model where a psychiatrist would see the patient, give recommendations to the PCP, et cetera. Obviously, that's not the most cost-effective way or the best use, especially as we have more mid-level providers, say in a COCM model, that can provide some of the more working with patients, et cetera. So we had been looking at that model for a while and thinking about how can we incorporate a broader care team, how can we make this more efficient, and that's really where collaborative care came along. And so one of the things we were excited about with NeuroFlow was the ability for us to, since we work with so many systems outside of MUSC, being able to modify the platform for these different use cases. So what would it look like to have NeuroFlow internally for our MUSC primary care? But what about for external sites that maybe want to participate in a collaborative care model in partnership with us? How will we manage our patient data, manage our registries, et cetera? And NeuroFlow really seemed to be a great solution for that. And then as we start innovating, because we are an academic medical center and this is top of mind, a lot of folks start to have really exciting ideas. So one of the projects I'm excited about, it's not funded yet, but we'll see is work happening in the ICU recovery space. So,
Yeah.
We know that folks leave ICUs often with a lot of need for occupational therapy, physical therapy, but there's also a lot of behavioral health needs. And so what would it look like to layer on a COCM-like model or a platform like NeuroFlow for patients that are getting discharged from the ICU, just to provide that extra level of behavioral health support as they're going through this really critical transition time. We're also looking at what this might look like with some of our university partnerships where we contract our psychiatrists, provide some psychiatry care. So what would it look like to use this for more of a population health approach in a university setting where students get access to NeuroFlow? It helps screen and identify students that need to come into the counseling center or the health center to get more in-depth care, but it provides a lot of great, preventative resources around sleep hygiene and mindfulness and some of these things. So really trying to think, as I mentioned, we're trying to reinvent healthcare. So how can we get information out into patients' hands, into their phones, screen and identify patients differently to get them into care?
That's amazing. And we're super proud to be partnered. Yeah. I mean, it's just awesome. We started out, I forget, how many clinics did we start in?
Yeah, it started out as a pilot in 4 clinics, so for our primary care, 4 small rural primary care clinics, and we evaluated it using some implementation science approach. But since then, through grant funding and advocacy within our health system, we are now going to go enterprise-wide across all of our 62 primary care offices. We're talking with OB, they want it. A lot of folks are interested. So.
We're excited.
Yeah.
It's an honor to get to work with you. And I have family down in South Carolina too, so I never asked them, but I wonder if they're on NeuroFlow. It's possible.
Yeah, there you go.
Ryan, how can people learn more, get in touch if they want to collaborate and work with you?
Yeah, well, one of the things just to highlight is MUSC is a HRSA-funded telehealth center of excellence. So as part of that, you can find us online on LinkedIn if you just Google HRSA COE or telehealth COE. But as part of that, we provide technical assistance to folks interested in getting telehealth off the ground, to health systems, looking at strategy. It's part of our goal and mission. Even just at this NeuroFlow meeting, I met someone who was interested in one of the trainings. We have psychologists that do TFCBT for peds over telehealth, and as part of that, she's like, "Oh, I know you guys. I want that." So all that to say, if folks are interested in some of the resources, the research we're doing, some of the trainings we're doing, you can just go to telehealthcoe.org and you'll find us there.
That's telehealthcoe for Centers of Excellence.org.
Yep.
We'll make sure to put that in the show notes. Ryan, thanks so much for joining me. It's a pleasure to have you at the summit.
Really, it's great partnering with NeuroFlow, and it's been great being here at the summit.
And thank you all for listening to this episode of Bridging the Gap. Be sure to subscribe to the podcast, get more insight, innovative healthcare and technology leaders, and check out more at neuroflow.com to learn more about how we support behavioral health and integrated care models. Thanks again for listening, and we'll see you next time on Bridging the Gap.